Okay, I would like to introduce our next speaker, who is going to discuss current trends in melanoma treatment. Please welcome Dr. Anna Pavlik, who is an associate professor in the Departments of Medicine, Oncology, and Dermatology.
Good morning, and thank you all for attending our skin cancer awareness seminar. I'm going to continue to speak about treatment of distant disease, since Dr. Hale talked about early disease. Dr. Berman kind of talked about the management in the middle. And, okay, volume is never a problem for me. So I'm going to bring up the tail end and talk about distant disease and what we're doing here at NYU in order to try to make a breakthrough and find a way to control this disease when it goes to other parts of the body. So this was just reiterating what Dr. Hale had said about how melanoma is the most common cancer and it's on the rise. And this is a picture of what melanoma has done over the course of the last 70 years. And it's becoming more and more frequent and diagnosed earlier, fortunately. But it also means that as more patients are diagnosed, more patients are also developing distant disease. And so my goal today is to talk about some of the investigational therapies that are going on with the treatment of metastatic melanoma. Why am I talking about investigational therapies? I'm talking about investigational therapies because melanoma, unlike other cancers like breast cancer or lymphoma, is a cancer that is not sensitive to most types of treatment. There are some cancers that are very sensitive to chemotherapy, some that are very sensitive to radiation, some that are sensitive to both, but melanoma in general has a tendency to be very stubborn and very difficult to control once it leaves the area where it started and goes to other parts of the body. So I'm going to talk about 3 different types of research that we've done here and that are being explored as ways to control distant disease. The first is looking at antisense therapy, and we'll talk a little bit about how that works. We'll also talk about targeted therapies, and for those of you who read the New York Times, about a month ago there was a 3-day series on targeted therapies, and we're also participating in that type of research. And then we'll also talk about pathway blockers. So when we talk about antisense therapy, we talk about a way in which we take a drug that tries to essentially confuse the working mechanism of the cancer cell. And we know that there are proteins that cancer cells make in excess, and one of those is called BCL2. And BCL2 regulates cell death. And it also may be very important in why melanoma can be so stubborn and resistant to chemotherapy. So what we've done is we've tried to take a drug that will block BCL2 mechanisms that the cell uses to produce these proteins. And so in order for cells to make proteins, DNA makes RNA and then makes a protein, and proteins get excreted either onto the surface of the cell or inside the cell. What we're hoping to do is take a drug that blocks the middle mechanism so proteins are not produced. Why is this important? It's important because this is a cancer cell. And the cancer cell has lots of mechanisms by making proteins. And when we try to give cancer cells chemotherapy, essentially chemotherapy acts as a death signal, and it tells the cell it's going to die. And ultimately that happens. However, with melanoma, because melanoma makes an excessive amount of this BCL2 protein, this protein coats the outside of melanoma cells, acting very much like a force field and not allowing chemotherapy to get in and kill the cell. And so cells are very resistant to treatment. When we give patients this BCL2 blocker, what happens is the cell can't manufacture as much of the BCL protein as it used to, and now your force field has holes in it. Those holes will allow the chemotherapy and or the radiation or other drugs to penetrate the cancer cell, and so we now can kill those cells. Well, how do we know that that works, and why do we know that it works in melanoma? Well, we always start out doing our research with either cell lines or animals, such as mice. And this is a mouse by the name of Fred, and Fred has a lot of BCL2. What we do is we can actually insert a gene within Fred so that Fred doesn't make any more BCL2. And we were concerned when we did this because BCL2 is also found in small amounts on normal body cells. And so we were afraid that if we prevented this mouse from making BCL2 protein, that he may not survive. Well, lo and behold, the mouse is very much alive. However, look at what color he became. And why is that important? That's important because a white mouse says that there's no melanin production. Melanin is the pigment that's produced by melanocytes. And melanocytes are the cells that cause melanoma. So from Fred, we were intuitively thinking that, wow, wouldn't this be a great drug to give patients with melanoma, because we can get in there and we can reduce the number of cells that make melanin and cause melanocytic death. So we sat and we looked at a number of different drugs that we use in melanoma, and we added this drug, this BCL2 drug called oblamersin, OBL here for short, and saw what we could do in the laboratory to try and kill melanoma cells. Well, when you just give the BCL2 inhibitor, you could see that some melanoma cells die. This is a standard chemotherapy drug, and so pretty much the same amount of cells would die if you gave it by itself. But when you give the BCL2 drug with this standard chemotherapy, you could see that you did even better. Well, we added a third drug into the mix, which is another chemotherapy drug, and look what happens. We had a whole lot more of the melanoma cells being killed. And so seeing that in the laboratory, we brought this forward to the clinic and did a clinical trial, combining these three drugs and giving them to patients with what we call metastatic melanoma, or melanoma that's gone to other parts of the body. And as you can see here, this is a CAT scan, and a CAT scan is essentially a three-dimensional image of your body where we could look at the anatomy of what's inside and see tumors. This is an enlarged lymph node in somebody's pelvis, because these are the hip bones here. And here's your anterior hip bone. And here you can see after treatment with this BCL2 drug, that tumor has disappeared. This is an image of what's called a PET scan, and some of you may or may not be familiar with a PET scan. A PET scan is a test that uses radioactive glucose or radioactive sugar. Why is that important? Because cancers use sugar very quickly, and they have a very high metabolic rate. Other things that use sugar quickly are infections and inflammation. So just because you see something that's, quote, hot or light up on a PET scan, it does not mean that it was cancer 100% of the time. It could also be inflammation or infection. And that's where the doctor needs to interpret what this means on your PET scan. So looking at the PET scan, you can see that this is an outline of a body. These black things are someone's kidneys, because the glucose will get excreted and removed from the body through the kidneys. But here's the spine, and you can see the outline of the arm. And this big black line here is melanoma. So it's what Dr. Berman was describing as in-transit metastases going up the patient's arm. You can see here there's a dark spot. That's a spot of melanoma in a lymph node. You can see a dark spot here. That's a spot of melanoma in somebody's lung. And even here, this is a woman. You can see that the melanoma had spread to her breast as well. Now here after treatment, and you can see July to September, so it's a very short period of time, in a matter of 2 months, the breast melanoma is gone, her lung melanoma is gone, and although her arm melanoma is still there, it is significantly better, and the lymph node is gone, and this patient continued on treatment and continued to have a good response to therapy. Another way that we're trying to combat melanoma is to get away from chemotherapy and trying to harness the body's immune system. And in such a way, we've developed what's called monoclonal antibodies that will try to turn on your body's immune system to recognize the melanoma as something that doesn't belong and attack the melanoma without giving you any type of toxicity from chemotherapy. So we're going to talk about one of the most active monoclonal antibody / immune system drugs that we have that's expected to probably be approved for use in melanoma, hopefully by the end of the year. And so the drug I'm talking about is a monoclonal antibody, which is essentially a drug that targets a specific part of your immune system and turns it on. And so we'll be talking about this Ctla4 monoclonal antibody. And why is it important? It's important because it really turns on somebody's immune system. And let me show you how it works. So here is your T cell, and your T cells are essentially surveillance cells that are out scavenging around your body, looking for things that don't belong. And when they come across something that's foreign or doesn't belong, they develop an immune response. Well, here's your T cell, which now hooks up with your activated antigen cell, and these are cells that are normally found in your body and do this all by themselves with no help of our own. And the T cell, when it hooks up with this antigen presenting cell, will suddenly start producing all of these chemicals within your body that triggers this immune response. And that's why when you get a splinter in your finger, your body recognizes that splinter as being something that's foreign. And what happens? If you don't remove the splinter, your finger's going to become red, it's going to become hot and swollen, and you're going to get pus that forms around where that splinter is, because that's your body's immune system fighting to reject what's foreign and get it out of your body. Well, that's what we're trying to do with this drug in treating melanoma. So these T cells are now activated, they're ready. They're putting out all these chemicals. The most potent immune stimulator is called IL-2, and it causes a big immune response. But our bodies are very smart, and our bodies don't like to let things go haphazardly and uncontrolled. So after a while of being activated, this T cell produces a receptor here, which you see wasn't present on this part of the cell because the T cell here is inactive. After a prolonged period of activation, the T cell produces this receptor, and this receptor really, really likes B7 on your antigen cell a whole lot better than it likes CD28. And guess what? When you get the binding of CD4 to B7, you shut down your immune mechanism. So all your immune function for attacking tumors or foreign bodies will stop. Well, in treating melanoma, we want to keep this going. So we were able to design a protein called a Ctla4 protein, which comes in here. Nick, let me show them. Wrong slide. It comes in here, and that's a really terrible picture, but the Ctla4 monoclonal antibody will bind to Ctla4. So Ctla4 is not allowed to bind to B7 anymore. So if you put a blocker on Ctla4, your T cells remain active. Well, what side effects do we get from something like this? Because, again, it's not chemotherapy, so we're not going to give people hair loss. We're not going to give them nausea and vomiting, and we're not going to drop their blood counts. We are, however, going to give them immune side effects. And those immune side effects come in the form of itching, rashes, and severe diarrhea. And this is a picture of what some of those rashes will look like when we give this drug. And again, not everyone will get these side effects, but we sit down and tell patients, this is what you need to look for, and you need to let us know so we can help control these should they happen. And finally, the last topic I want to talk about is a pathway inhibitor. And this is the agent that has really been in press very much because we've been able to look at melanoma tumors and analyze their genetics and look to see, is there anything unique within that tumor that we can make a drug to block in order to control melanoma growth? And what we found is that melanoma tumors will, 50% of them will have what's called a BRAF mutation. And I know this is a crazy, complicated slide, but the more we get to know about melanoma, the more we get to know that it uses multiple pathways to try to get from the lymph node or the primary to other parts of the body. And as you can see here, the most prominent pathway is this RAS-RAF pathway. Well, we've now been able to create a drug that blocks this pathway from happening, and we had hoped that by blocking that pathway, we would be able to put up a roadblock so the cells couldn't divide anymore. And this is how we find out whether or not patients have this BRAF mutation. We actually have to test their tumor, and we have to look at it at what's called a genetic analysis here to see if you have this three-peaked abnormality called the V600E mutation that allows the drugs that we have to bind to this site and shut off the tumor. And again, this is showing you exactly how the drug will work. For anybody in the audience who doesn't like gory pictures, I'm going to show you some examples of patients that have been treated here with this drug, patients who were actually told that they had nothing else to be offered, and show you some of the pretty results that we got very, very quickly with this drug. So this is the drug that was in the Times, and it's called PLX4032. And again, it's not a chemotherapy drug. It is a targeted therapy. So patients are not going to get the same side effects as with chemotherapy, and they're not going to get the immune side effects like the Ctla4 drug we talked about. We're giving them different side effects, such as, again, we like to give people rashes. But we can also induce some squamous cell skin cancers as a consequence of these drugs. So we're trying to get rid of one skin cancer, and sometimes we wind up giving them a second one. But as you heard from Dr. Hale, squamous cell skin cancers are very easy to control once we diagnose them, and we just remove them. And patients are happier getting squamous cell cancers when they know that their melanoma is now under control. And this just goes to show when we give this drug to 100 patients with melanoma, 70% of them, or 70 out of the 100 patients, are going to respond, and their melanomas are going to shrink up very quickly. So this is a picture of one of my patient's chest walls. This is his right chest wall, and these are tumor nodules that are essentially going up and down his right chest wall. This is underneath his arm. This is where he had a lymph node dissection. And so he got started on this PLX4032, and within 2 weeks, look how nice and flat. All of those nodules have regressed. You can see he's got some scars here. He no longer has the drainage or the oozing. And again, this drug, when it works within 2 weeks, and patients really notice a very visible change very quickly. Believe it or not, this is another patient's left chest wall. So this is where, and this is a gentleman, so this is where the gentleman's right breastplate would be. And you can see these are all melanoma tumor nodules. It was infected, it was bleeding. It was really very horrible to see when he came in. And this is 2 weeks later. Although the melanoma is not gone, you can see it's no longer bleeding. It's now crusted over, and I can tell you that this gentleman is still on this drug, and all of the tumor underneath has fallen off, and he's got nice pink skin underneath. And the most exciting thing for him was 2 weeks later to come in and say, "Hey, doc, look, I got my nipple back." Because it was gone for several months. So the pictures I showed you were very exciting, but people also say to me, well, that's really nice, but that's melanoma that's on the skin and on the lymph nodes. What about melanoma that goes to vital organs like the liver? And here we go back to a CAT scan, and this is somebody's liver, this whole big thing here. These are kidneys, this is the spine, this is the liver. The big, ugly black spots in here are melanoma tumors within somebody's liver. And here, after just 6 weeks, you can see how the tumors have shrunk, and you can see they continue to shrink as the patient remains on treatment. And since you're all experts now in what a PET scan looks like, we go back to the PET scan. Why? Because PET scans are good ways of looking at patients that have lots of disease in an extremity. And you can see the starting date, day 0, and here's day 15, to show that I'm not fibbing when I say how quickly this drug works and causes tumors to regress and get better. And so in conclusion, I hope I got you all excited about some of the really interesting work that we're doing here to try and combat melanoma when it goes to other parts of the body. And I really firmly believe that with the science and making melanoma a much more personalized type of tumor where we look at the tumor and identify things within the tumor that we can create drugs to stop those tumors from growing, we're really going to be able to make headway very soon, and more people will survive metastatic melanoma. Thank you for coming.